Is the meeting canceled or not canceled?
Hey, Michelle, it's going to start at 1.
Okay. Thank you.
All right, welcome everybody. It is 1 o'clock. I'll give it a few more minutes just for other people to join. If you can please type your name into the chat box with the name of your organization as well. That helps us a lot with attendance for today. Okay, just give it 2 more minutes for any last minute stragglers, and then we'll go ahead and get started here.
Hi, Martine. Sorry
Okay.
that we're late. We had another training session that we're just getting out of. I would think maybe we might have a couple of other people that would
Okay.
be joining as well. If we can just wait a moment, please.
Yep.
Thank you. Hello, everyone.
Hi. Hello.
Hello.
Good afternoon.
I
My lighting is
was
weird.
telling Martine, Diane, that we might wait just a minute just because
Yeah.
we have some other people that might be coming from our other training session.
Yeah. Perfect. Are one of you are recording?
Yep, it's recording.
Perfect. Thank you. Mhm. I'd probably just give it a couple more minutes and then we could probably start.
Yeah, I was thinking maybe like just one.
Yeah,
just to give everybody time to.
their time. Yeah.
Yeah.
Okay, and for those that join in just not that long ago, if you can please type in your name and the name of your organization in the chat box, that helps us with the attendance for today.
Martin, I think you're okay to start. I think it should
Okay.
be okay.
Diane, can we wait just 1 second? I've got a couple of people that just texted and said that they're running to the restroom. They'll be on the meeting. I'm sorry.
That's okay. We could probably just like go through like the introductions.
Yeah, that would be great.
So it's like the next slide, I think, is the.
Can you guys see my screen?
Yep.
Okay, perfect. All right, welcome everybody. We're gonna go ahead and get started just with introductions, just so we give time for those that went to the bathroom to come back. And if at any time you need to go to the bathroom, please feel free to do so. We do have a break halfway through the presentation for today, a 10-minute break. And so we'll go ahead and get started with the presentations. And so this is today's agenda. We're gonna have the welcome and introductions by Sam. We have the collaborative care presentation that I will be talking to that. We also have some great speakers lined up for today from Community Health of Central Washington, Becky Starnes, Michael Clement from Merit Resource Services, and we have Armelia Bassini from Lord's Health that will be talking today. There's a break. We'll also be having a breakout group / whiteboard activity for some questions that we have for you guys today, and then we'll do the closing and discussion.
Hi, I am Sam Wardell. I'm the Director of Practice Transformation for GCACH, and welcome everyone.
And I'm Diane Halo. I am the program director here, and I kind of help with all the managing of all the projects that we have going on and the different program areas that we are doing at this time.
Jack of all trades, right, Diane?
Yep.
And my name is Martin Sanchez, Senior Practice Transformation Navigator with Greater Columbia ACH. Okay, so today we're going to be talking about collaborative care. And as we know, there are benefits that come along with collaborative care, both benefits to the patient and to the providers that are part of the care team that make up this patient's care team. But then there are also some barriers, that just are there, either historically there, or just barriers that come up as we're exploring the collaborative care model. Here, this slide is talking about the benefits of the collaborative care. So some of the benefits are team member empowerment. So this enables for others to be able to offer recommendations in treatment for better patient outcomes, whether that would be the primary care provider, behavioral health specialist, SUD provider, a psychiatrist. There is a whole team behind a patient So when they are able to offer recommendations for treatment because they're the experts in that area, or they want to share their thoughts with the rest of the care team, this empowers them to feel, hey, I'm putting forth my best effort to provide the best advice for this patient so that they can have better patient outcomes. Another benefit is that it helps close gap communications. We know that there are a lot of barriers. Then we'll go over some of those barriers here in just a little bit when it comes to communication. But when there is that communication between the different clinical settings, there patient information is not as easy to get lost. And here it says vital patient information can be lost, which is true. Sometimes if you say, a metaphor is, sometimes the right hand doesn't know what the left hand is doing. And in this case, that can happen as well. When the primary care provider doesn't know, who else is providing care to this patient outside of his office. So it is important that there is in the collaborative care model that there's as much communication as possible so that the patient information doesn't get lost in transition or is just sitting there kind of in that silo area. Another benefit of the collaborative care minimizes readmission rates. Here in the greater Columbia region, we have two of the busiest ERs in the States, in Yakima and in the Tri-Cities. And so, having this collaborative care model really makes an impact on the readmission rates, whether that be to being inpatients or, revisiting the ED. Which we know that's a big contributor to the cost of healthcare. And so, the minimizing the readmission rates is also one of the metrics that we are working towards to reduce the readmission rates here in the greater Columbia region. And so having this in place, helps us towards reaching that goal. Collaborative care also promotes teamwork and team mentality. They're able to provide support to each other and rely on their expertise, similar to team member empowerment. This, promotes teamwork. It's not just, the patient is not just seeing one provider, they can see multiple providers. So providing, support to each other, whether that be, hey, I'm the prescriber, this is what I'm prescribing, our patient, here's the list. And so that helps with, just having that teamwork in place and getting into good, a good rhythm of relying on others and asking for advice when they're the experts in that area. Collaborative care benefits. Continuing collaborative care results in patient-centered care. They contribute equally to patient's care, thus the patient shines as the unifying cause for care. So, we are using the patient-centered medical home as the foundation for change in the Greater Columbia Cares model. So all of our partnering providers that are part of this meeting that are doing this work, you guys are using this, either you guys are patient-centered certified already, the federally qualified health centers, or you guys are working towards being more patient-centered, which you guys have done a really good job with that. And really, the person that really benefits from this is the patient. They are at the center of the care, and the care team is around providing support to the patient, whether that be, primary care, behavioral health, substance use, dental, which is, another important piece. So, having that patient being at the center of care and really providing the care that they need is actually, one of the best practices that there is. Collaborative care also helps identify mental health issues before they become severe. About 60% of patients visit their PCP for mental health treatment. And we know that primary care providers are very, very busy, that, sometimes mental health, looking into that might not be their priority. So, that can kind of start going into a snowball effect and, getting worse and worse and worse until, it becomes so severe that they have to go to the hospital, they have to do a crisis intervention, they have to be hospitalized, thus again raising the cost of care for something that could have been prevented. So collaborative care model also looks more into going upstream, if you will, using that metaphor of catching the patients before they become more severe. So it is important that these health issues are identified before they become more severe. And one thing that all of our provider sites have done as well, a milestone 2B1, bidirectional integration. For those of you guys that are familiar with the milestones, a lot of our sites, all of them are now screening for behavioral health needs, whether that be with a PHQ-9, a GAT-7, the SBIRTs, the PHQ-2, some have a PHQ-3. They added an extra question. So they are working towards identifying patients in the different care settings, whether that be primary care, behavioral health, substance use, dental, skilled nursing facilities, hospitals as well that are doing this work are now screening. And they have different models to getting the care for the patients, whether that be having on-site a social worker or a behavioral health specialist or a psychiatrist, or having a telehealth, having a resource for them to be able to provide that patient with a resource. Collaborative care also reduces overall cost of medical care. Medicaid outpatients who frequently visit their physicians and receive both physical and mental health care achieve a 21% reduction in medical costs after 18 months, while those who only received physical care had a 22% increase in their use of medical services. So, that right there tells us a lot. It is a way to save the healthcare system money in the way, by focusing both in physical and mental health. So it's not just, just because I'm going to a primary care provider doesn't necessarily mean that, hey, I'm only going for my physical health. They can also, provide resources and provide treatment for your mental health. But again, we have to remember that primary care providers are very busy, and mental health care might not be their expertise. So that's why it's important to be and have a collaborative care model in place, whether that be the BREATHE collaborative, the having that co-location of the behavioral health specialist on site, or the AIMS model from the University of Washington. So those are the three models that we recommend to use. They're evidence-based, which we'll hear a little bit more from Amelia on the AIMS model a little bit later when she does her presentation. And I would encourage you guys to also learn more about those models. They're great. They have great benefit for both the patient and the providers. There are, like I mentioned earlier, there are also barriers to collaborative care. So it's not just, hey, let's explore this option. There are different barriers that affect the collaborative care. Some of those barriers are clinical barriers, the lack of provider knowledge of treatment guidelines and measurement based care, using your PHQ-9 and making sure that you're tracking those scores over time to see, hey, is my patient getting better or are they getting worse? It's important to know, how your patients are doing. It's not just, here, take this, questionnaire. Let me see how your mental health is doing, and kind of not worry about it. So we have to pay close attention to that, making sure that we track the assessment scores over time to make sure that they're getting better and not worse. And if they're getting worse, kind of do more work and come up with a better care plan for that specific patient. And again, it says on here, lack of provider knowledge. Always, try to still, educate yourself. What are the best practices? What are other organizations doing? So that, maybe we can adopt those best practices here, or workflows or procedures or policies that are in place. Another barrier is it's distinguishing physical symptoms from complaints related to to moods. So this is really important as well, making sure that, just because you're going to your physical provider, with a saying, hey, something is just not, feeling well, and might have to do because, your mental health is not there, but is manifesting in a different way, that the provider is not able to say, hey, it's really not your physical health. We really need to get you your mental health um, together, and provide you resources to make sure that it is that, and we're addressing the right condition, rather than testing procedures that are going to cost money, both to the healthcare and both to the patients, which some of those are very costly as well. Another barrier is not engaging patient in discussion of treatment options, including honest, open communication about meds and their alternatives. This is a milestone in the Greater Columbia Cares model. This is milestone 4A2, the shared decision-making tools. This is really important to include your patients and their care, to have them be the voice of their care, provide them with options. There's different medications to treat depression. What's going to be the best option for that patient. And there are different side effects. There's money. You can gain weight, lose weight, sleep more, sleep less. And so the seeing the patient, the different options, they can say, hey, let me go with this. If it works, great. If it not, then we come back to step one and make another decision. And that has proven um, to have better patient outcomes as well, because the patient, feels empowered in their care. They're making those decisions, and it's not somebody saying, hey, I'm gonna prescribe you this because I think that's the best option for you. Providing those options for the patient is also one of the best practices. And if the patient says no, hey, that's the patient's decision. Right now might not be the best time for that patient to say, hey, just I want to start medication. Sometimes they say, hey, I'm fine how I am, just leave it as is. And we have to respect that, as you guys as providers have to respect that, because that's their decision. What you guys can do is, bring in the next visit, bring it up. Hey, I know the last time on this, when we discussed it, you said no, but hey, what about now? Has that changed? Have you thought about it? And it can change from your first visit to the next. And so you can say, yes, I've thought about it. Here's what I want to do. And so, that's an option as well. Another barrier, and this is personally for me one of the biggest barriers, stigmatizing attitudes about treatment and poor communication between patients and providers. There's I've heard it. I'm and part of the majority of my work, is I meet with all of our providers that are going to practice transformation. And we hear this from, I hear this from them. Hey, that's one of the big barriers that there is out there, the stigma, especially for those patients that are, that are substance users. That is a big stigma for them, because, when they go to the hospital, or when they go to their primary care provider, if they have one, if they have a primary care provider, they they are hesitant to provide, treatment, to prescribe. And so, having that collaborative care where the primary care provider and their substance use provider are in communication is very important, because their substance use provider can have information that can be valuable to the primary care provider when they're talking to the patient, coming up with their care plan, coming up with options as far as their treatment. And same thing, if it is very important for the primary care provider to let their substance use provider know, hey, this is what I'm doing, this is what I'm prescribing, this is the care plan, here you go, here's the information. And that leads to better patient outcomes. But a lot of times that doesn't happen. There are still silos, within here in our region. Their primary care providers are more hesitant to establish care with those patients, just because of the stigma. They're more costly. They're not going to listen to the advice that we give them. They're not going to do self-management, which is that might not be true. It might be true for some patients, but for some, there can be really great benefits when there is that communication between the different providers, and the stigma is not there. Other barriers, organizational barriers, which is another big chunk of the barriers to entering into collaborative care. So impose limits on PCP time allowed for a comprehensive mental health evaluation. I'm sure all of you guys have gone to the doctor, and sometimes they see you for 5-10 minutes. They come in, hey, how's it going? What's going on? And they're there really quick. They're in and out sometimes. And so that having that limited time to really say, hey, I noticed on your PSQ-9 when you took it that it came back on you scored a 15, which is you're depressed. What can we do? How are you feeling? Are you seeing a behavioral health provider? Are you getting counseling? If not, here are the options. And so that really sometimes doesn't happen, unless there is the co-location of behavioral health, where the primary care provider has that easy access to behavioral health specialists, or which Amelia is going to talk to that more when we present. And so it's that's one of the barriers, at least in the primary care clinical setting. Historical protection of privacy and fears of violation of privacy. That's a big one. 42 CFR, is very important to follow, especially for substance use providers. And then HIPAA, but specifically 42 CFR Part 2, it can be a big barrier to many providers, just because they want to follow that guideline of privacy, and they don't want to violate it. That many times they're just like, hey, 42 CFR doesn't allow me to share any information, doesn't allow me to provide to talk to other providers about this patient. So we would just rather be a standalone and not really share information. What our sites have done here in the Greater Columbia region, specifically behavioral health and substance use providers, with the use of 42 CFR, there are ways that you can still be collaborating with other providers and still be following the guidelines of 42 CFR. You just have to be very specific. And if you guys say, hey, I would want to learn more about how those sites have worked around 42 CFR, still be compliant, and still be, sharing information, meeting with other providers, please reach out to us. We will have our emails here at the end of the presentation, and we can definitely connect you with those sites so you guys can ask your questions, and they can provide answers to you guys. The other barrier is confusion between primary care providers and behavioral health / SUD providers about the responsibility of a patient's care. So when there is that collaborative care, if there's not much education as to, hey, this is what collaborative care is, this is the purpose of it, and then these are the outcomes that we want to see. Many times people or providers don't know, hey, is this your patient or my patient? So there's really kind of who takes the responsibility for those patients. And when there is that collaborative care, whether that be through a memorandum of understanding, business associates agreements, making that language really clear as to saying, hey, these are the responsibility for us are these are your responsibilities, and agreeing on those responsibilities and having clear guidelines as to, okay, when it comes to this, these are your responsibilities. When it comes to this other stuff, these are ours. And again, having that clear communication, clear policies, clear procedures, having those agreements, having that wording specifically in place as well. The other barrier, which we have been hearing a lot about here in the last few years, is workforce shortages of professionals trained in evidence-based interventions. This is more towards all settings, especially behavioral health settings. We here in the Greater Columbia region, and really in all of Washington State, there is a really big shortage of behavioral health professionals, and so that limits, the number of patients that can be seen. That limits, the number of providers that are out there, which they get burned out pretty quick, especially if they have a big caseload on their panels. And so that's one barrier that we are working to address here in the Greater Columbia region. Diane has a program that's specifically for behavioral health, growing behavioral health providers here in the region. And so you guys can reach out to her if you guys want to learn more about that program as well. But workforce is a barrier to collaborative care as well. Financial barriers, which is a big one. When we provide services, where's the funding going to come? Are we able to bill for those services that that we're providing to those patients? And so funding and reimbursement issues for both primary care and behavioral and substance use providers, value-based purchasing, contracting with managed care organizations. It's one of the, I would say, it is a barrier here in our region, especially in behavioral health and substance use providers. There's not many PVP contracts out there for behavioral health and substance use providers. So most of the time, the reimbursement model doesn't work for the services that they're providing because they're not able to bill for those services. But our sites are still providing them because they see the value and they see the benefit of having those services, even though they're not able to bill for that. One of those services being following up with their patients after ED visits or being hospitalized. The primary care providers do get reimbursed for that if the appropriate staff member makes those follow-ups with those patients. But in the behavioral health substance use provider side, they're not reimbursed for that. But our providers, at least the ones that we are contracted with, are going to practice transformation, are doing it, and they have seen a great benefit. They have identified patients that have gone to the hospital multiple times in one day, and now they have that information and they're able to come up with a better care plan for that patient, and they're able to follow up saying, hey, I see that you went to the hospital 3 times. What's going on? How can we help you? um, it it has also helped them in identifying underlying issues for them going to the hospital, because maybe their patient went to the hospital because they had a broken arm, but did they break it because they were drunk, or were they on using some type of substance that they weren't supposed to, and they fell and broke their arm. And so it gives them more information, but again, it doesn't really allow them to bill for those services. So VBP contracting here in our region is very important, in all care settings, just so that there's more funding available to be able to provide all of the services to the patients. The other one, lack of reimbursement for the treatment of mental health for services such as depression screening, psychiatric consultation, and care management. And so the identification of high-risk patients. Part of the work that our sites are doing through Praxis Transformation is they are risk stratifying their patients, and they are finding those patients that are really high risk. So those are the patients that they focus on because they're the ones more at risk of going to the hospital, going to the ED, and if they can be, provide an intervention that doesn't allow that to happen for them to, get more severe and go to the hospital, it's a lot of case management that has to be done, a lot of connecting them with appropriate resources that they need, whether that be taking care of their social determinants of health, which affect our health in a big way. Why didn't you go to your appointment? A lot of times, that's what providers say. Hey, they didn't come. They must not really care about their health. But the case might be that, hey, they didn't have gas for their car, or they didn't have money for gas for their car, so they couldn't make it to their appointment. Or for those with diabetes, that are not being compliant with their insulin. Insulin is really expensive. So, they might be saying, hey, I can take it one day and not the next. And so kind of rationing it, which is not good. But, for them, it makes sense because, they don't have the means to purchase, additional insulin that they're going to need. So there's, a lot of barriers in that sense as well. Another barrier is billing restrictions for a medical and mental health visit on the same day. More if you are co-located in behavioral health and primary care, there is some limitations to that as how you can bill for being seen in the same day. So those are issues that we need to work on with the healthcare authority, the managed care organizations, providers come all to the table and come up with a solution for that, because that's a barrier that's affecting people. And if we want to see better outcomes, health outcomes in both physical and mental, all of these barriers really need to be addressed. And with the challenges and opportunities, there's or barriers and benefits. There's also opportunities for collaborative care. One of those opportunities is changes in healthcare policy and reimbursement models. I mentioned VBP contracting that focuses on value of care rather than the number of patients that are seen or the number of procedures that are completed. Really looking into, hey, is your patient population getting better? And if it's not, why? Why are you guys implementing evidence-based models that are in place? Are you guys really tracking PHQ-9 scores, GAT-7 scores, SBIRT scores, A1Cs, blood pressures, all that good stuff. So there needs to be a shift into looking more into contracting that's going to focus on the value of care rather than the volume of patients that are seen. Another opportunity, health information technology. So implementation of ONC certified EHRs, which is one of the things that we worked on here with our sites that are going through Praxis Transformation. One of their requirements was that if they weren't on a ONC certified electronic health record, they needed to switch one. And why? Because hits on meaningful use. There's better way of sharing data within, from electronic health record to electronic health record. And so there's a lot more benefits. And, that also helps with billing, makes billing a lot easier. And there's less chance for errors when billing, when there is an ONC certified EHR that has been implemented. Another opportunity, meaningful use. This improves the quality, safety, more efficiency, and reduces health disparities. And then another one is talking with new and existing patients about advantages of collaborative care. Many times patients don't know that, that providers can talk within one another with when they agree that, hey, yeah, you can talk to my doctor and share some of my information, and really educating them and providing information and saying, hey, these are the benefits. It's not just because we want to share your information and have it out there. It's for a reason, and this is the reason. And so really working with your patient population and educating them and their families, not just the patients and the families, because many times families are also involved in the care of the patient. So, that education piece is also really important. Other opportunities, educate patients about release of information, what that is, and why they need to sign it, or why it's important for them to sign it. And again, like I mentioned earlier, if they say, hey, I don't want to sign it, I don't want my information shared, that's their decision. That we have to honor that. And but kind of in later visits saying, hey, have you thought about signing the release of information more? Here's more education. Maybe we can you can connect them with a patient that has signed it and has seen kind of the benefits of having that in place. And connecting them so that they can, peer-to-peer always works, rather than a provider telling you, hey, sign this, and when they hear that from another peer, it's more of an impact for them, because it's not somebody that's a professional, if you will, but it's more of a, hey, that's a patient that's, for the same clinic that I go to. So, it must be of a benefit, and just, kind of doing education around that piece. Another opportunity is help patient find primary care provider or behavioral health or substance use provider if they do not have one. And so this is another piece that our sites that are going to practice transformation have been working on. Hospitals need to identify patients that do not have a PCP and make a referral so that those patients can establish care. Behavioral health and substance use providers are also asking their patients if they have a primary care provider. If they do not, they try their best to get them connected to a primary care provider. But again, the stigma is there, that they have a harder time establishing care with primary care providers. And for behavioral health and substance use providers, if you guys can find a primary care provider partner to partner with, and enter into a memorandum of understanding, business associates agreements, to say, hey, when I send my patient to you guys, can you guys make him a priority and establish care as soon as they can, just because that patient population can one day can say, hey, I do want to establish care, but say if it takes 2 months, 3 months, they might say they're not going to see me no more, so they might not even show up. But when there is, they can be seen faster, say within a week or two, that's an opportunity that's there. But again, it's hard to enter into those agreements with a primary care provider, just because of, again, the stigma and kind of, just the logistics around of how, that would work. Michael Clement from Merit later on will tell us, they have one of those collaborative, the MOUs, Memorandum of Understanding, in place with a primary care provider that they were able to obtain. And so he will share, more on that. But for primary care providers and behavioral health substance use providers that are on here, I would highly encourage you guys to explore, collaborative care with the different care settings, just knowing that, it's very valuable to not only you guys, but, more valuable to the patients and their care. So, and if you guys want to say, hey, I'm interested, just let us know. We can try to see who else is interested as well. Establishing collaborative care plans, making sure that the care plans, if there is the release of information in place, that the care plans are collaborative with all the care settings to make sure that everyone knows, what's going on with the patient, what treatments have been provided to the patient, what medications, if there have been any medications provided to that patient, so that everybody's on the same page, that they're providing, the best care possible that they can, and also, providing, using the best guidelines based on the information from the other providers that are collaborating into those care plans. The other opportunity is establishing communication with behavioral health SUD providers and PCPs as a routine of service. Again, a little challenging, just because of 42 CFR, HIPAA, and the different means of communication. Is it a secured way that you guys are communicating, or is it a meeting, established meeting that you guys have? But making that a routine, again, is the best practice, just so that, everybody's on the same page, and everybody knows what's going on with the health of that patient. And here, next, we have a video that maybe you guys have already seen, but it's a really great video. It's talking about integrated care, which is, what we're talking about today. And as we're listening to this, just kind of try to point out, hey, his kind of the important points that kind of stick out to you guys as we're hearing the video here. And so here I will play it, and hopefully the sound comes on, plays for you guys. If not, let me know, and then we can get that resolved. So here we go.
Shortly before after my 40th birthday, I got in a car and merged onto the highway on the way to work. And suddenly my heart was pounding and my chest was tight and I couldn't breathe. So I pulled off to the side of the road. I made a quick phone call to my wife, Sherry, and left her a brief message that I loved her. And then I called 911. A short time later, the paramedics arrived and they loaded me onto the ambulance. And they put nitroglycerin under my tongue. Nitroglycerin. I thought, wow, they must think I'm dying too. So they loaded me into the ambulance and they took me to the local emergency room. The emergency room doctor there ran a number of tests, and she came back and said to me, not really sure what's going on with you, but you don't seem to be in any immediate danger. And so I was discharged from the hospital with a number of referrals for follow-up. And so then over the next several weeks, I saw a variety of specialists, received a variety of diagnoses, was started on a variety of medications to treat everything from heart disease to acid reflux. And then, a couple months later, it happened again. But this time I was able to immediately get in to see my longtime doctor. So he sat me down and he said, Tom, look, there is nothing wrong with your heart. What's going on with you? And after a conversation about everything that was going on in my life in that time, he gave me the correct diagnosis of having depression and anxiety. And it was manifesting itself in these terrible anxiety attacks that were making me feel like I was dying. I was really lucky. I'm a mental health professional. I went to my medical provider thinking I had a medical condition, but he saw the larger picture. He saw me as a whole person, and he was able to identify what I was facing were challenges related to my mental and emotional well-being. A short time later, the paramedics arrived and they loaded me onto the ambulance. And they put nitroglycerin under my tongue. Nitroglycerin. I thought, wow, they're going on with you, but you don't seem to be in any immediate danger. And so I was discharged from the hospital with a number of referrals for follow-up. And so then over the next several weeks, I saw a variety of specialists, received a variety of diagnoses, was started on a variety of medications to treat everything from heart disease to acid reflux. And then, a couple months later, it happened again, thinking I had a medical condition, but he saw the larger picture. He saw me as a whole person, and he was able to identify what I was facing were challenges related to my mental and emotional well-being. Unfortunately, this is not the norm in our country. The medical, mental health, and addiction treatment systems are existing in these separate silos, and they're creating this fragmented, difficult to navigate maze, a game of hide and seek in order to find the care that one really needs. This leads to overly narrow diagnoses and at times really bad outcomes for folks, where they end up in emergency rooms, hospital beds, and other institutional settings at the highest cost and likely the least effective treatment in the long run. So to see how this plays out in real life, let's follow the story of Emma, who's in 4th grade. Emma's teacher expresses concerns that she's often absent-minded in the classroom, at times she's falling asleep, and she's making frequent visits to the school nurse with a variety of complaints of aches and pains. Emma takes her to the doctor. Her doctor, after a brief visit, gives her a diagnosis and sends her home, likely without having evaluated or treated all her needs. So how does that play out for Emma? Continued difficulty in the classroom, maybe getting in trouble at school, leading to tension at home, adding to the stress of whatever she's already trying to cope with? That's an example of how the fragmented healthcare system is failing us. But thankfully, this is changing. We're changing the way we're caring for people's mental and emotional well-being as well as their physical health. We're recognizing that mental health conditions and addictions are genuine health conditions, just like heart disease or diabetes. And this shift is laying the platform to move away from this fragmented system to one that is more integrated and treats the whole person. It's leading to integrated care experiences. So how would this change for Emma? Emma's mom takes her to the doctor. The doctor now realizes, wait a second, there's more going on here than just a physical illness. Emma and her mom are able to go down the hallway and make an appointment with a social worker, one that specializes in working with kids. And that social worker is able to take the time to make a full assessment of all of Emma's needs. Now, the social worker, the doctor, Emma, and her mom are able to work together to create a care plan that addresses all those needs. This is an example of how an integrated care approach can be transformational in the lives of those that we serve. There's another innovation I want to share with you. It's the growing recognition in the healthcare system that unless one's basic needs are met, good overall health is very difficult to achieve. We refer to this as the social determinants of health. You may be familiar with Maslow's hierarchy of needs. Developed by Abraham Maslow, this well-accepted theory maintains that unless one's basic needs are met, it's hard to achieve those higher level goals and aspirations in your life. The social determinants of health is a similar theory that maintains that unless one's basic needs are met, good overall health, again, is very difficult to achieve. Simply put, it means that if people don't have a decent, affordable place to live, access to adequate amounts of nutritional food, and other basic needs met, all the best care in the world may not make a difference. What if Emma and her mom are living in a homeless shelter or in their car? What are the medical and behavioral health providers supposed to do about that? I'll tell you what. Increasingly, medical providers and behavioral health providers are partnering together with social service providers in order to develop comprehensive care plans. I mean, now we're really getting it somewhere. Not only having Emma's medical and behavioral health needs met, but also her basic needs, and everybody working together as a team on her behalf. There's a movement going on around the country and here at home where medical providers are increasing their ability to identify and assess the behavioral health needs of those that come to them for care. Also, they're increasing their ability to provide treatment for those behavioral health needs. Coinciding with those changes are changes that are happening in the behavioral health system, where behavioral health providers are increasing their ability to recognize the medical conditions of those that come to them for behavioral health care. And they're increasing their ability to treat those needs, either within their own practices or in partnerships with other medical providers. And so you can begin to see we're trying to aspire to create this no wrong door system in order to get the care that's required for your whole person. It's estimated by the American Psychiatric Association that 1/3 of all adults that are receiving medical care also have a behavioral health condition, such as depression or anxiety. If there are 300 of us here today, that means 100 of us are facing these challenges. 1/3 of the neighbors in your neighborhood, 1/3 of the students in our schools. Additionally, 70% of people who are receiving behavioral health care also have a coinciding medical condition. So this can range from persistent headaches to insomnia to more chronic conditions such as diabetes. And guess what? An integrated care approach will not cost more money. In fact, we think it will not only dramatically improve care, but it will do so at a lower cost. It's estimated that an integrated care approach will save commercial insurers, Medicaid and Medicare, $26 to $48 billion a year just in our country alone. How is this possible? Well, it's possible because when people get all the care they need, when they need it, in the communities in which they live, they're able to avoid those higher cost stays in emergency rooms and hospital beds and other institutional settings, again, likely at the least effective care for them in the long run. We can do so much better for those of us that have heart disease and also suffer from depression. And we can do so much better for those of us that face mental health challenges and need specialized assistance in order to care for conditions such as diabetes. And we sure don't need nitroglycerin to be put under our tongue to know that now is the time to begin to make these changes. We can begin to work together as a community, asking individuals to join in together with us in order to face these issues, not just alone, but together, core issues that we face in our community, such as chronic homelessness, addiction, and mental illness. For example, in the city of Everett, the city is partnering with law enforcement, medical providers, mental health providers, addiction treatment providers, low-income housing providers, and social service providers in order to create comprehensive care plans to help the chronic homeless in our community. All of us bringing our expertise to the table and developing holistic care plans one by one to help these communities rise up off of the streets, get a place to live, get a job, and rejoin us as community members. If you know someone that could benefit from an integrated care approach, would you suggest a resource? Because they do exist. The Everett Clinic, for example, provides behavioral health treatment to those to whom they also provide medical care. And at Compass Health, we are beginning to more and more provide medical care to those that come to us for behavioral health care. We don't have to stay stuck in this system that isolates us from the care that we need. And we can imagine and we can envision what it would begin to look like if integrated whole person care were widely practiced in our communities. People who are frozen in their situation, having their suffering eased, and regaining their lives of emotional richness. Again, the homeless, having all the systems come together and approaching them with a whole person care approach that really allows them the best opportunity possible to get off the streets, get into treatment, get a place to live, and begin that road of recovery to a life that's full of purpose. Parents who are ill and addicted, getting their suffering eased so that they can be the parents that their children need them to be, to move beyond the hopelessness, despair, and anger, and regain the confidence and enthusiasm to raise their kids. I think this is our best shot at attacking the opioid crisis both across the country and here at home. So many people with opioid addictions have everything going on. They have medical challenges, addiction challenges, mental health challenges, basic need challenges. And unless we come together and bring forward an approach that addresses all those needs, I don't think we're going to make any progress in terms of helping them as an individual or in attacking the problem as a whole. A friend of mine told me about an experience that some have when they're receiving treatment for AIDS. It's called the Lazarus effect. And in the treatment process, they move from being frail skeletons, and then they rise up out of that process, the perfect pictures of health. I've seen this happen at Compass Health. People come to us and they're at the end of their rope. They don't have a home, they're ill, they have mental health challenges, they have addictions, and they don't have any hope. But when we're able to embrace them as a whole person, we give them that best opportunity to raise them up and have that experience to regain lives that are full of recovery and purpose. And so I ask that you would join me in shaping and sharing a new future of health that treats the whole person and gives all of us the best opportunity to live lives that are full of good health and happiness. Thank you. Thank you.
Okay. So hopefully you guys liked that video. To me, it was really informative and it hit to the points of today's topic. So that's why I decided to share this video with you guys. We will be going to a break for 10 minutes. So I will see you guys at 2:12. All right, welcome back, everybody. It is time to get started. This next section, we will be having 3 guest speakers that I mentioned earlier. We're going to be having Becky Starnes. She is the Connect Program Director going first. We'll have Michael Clement, Clinical Supervisor from Merit, second. And then we will have Armelia Busini, Behavioral Health Specialist at Lourdes, go third. And so let me, so here is Becky. I will start with your bio first. Becky Starnes, MSW, is the Connect Program Director at Community Health of Central Washington. She graduated from Eastern Washington University with a master's degree in social work and has over 20 years experience working in non-for-profit organizations, including 12 years FQHC experience. She has been in her current role since the beginning of the program in 2016. Becky is passionate about the patients that she serves and feels honored to hear their stories and help them along their journey to recovery. In her spare time, Becky enjoys traveling, especially to the beach, camping, hiking, and biking. Michael, you will give us a little background on you when you present. And then Armelia. Armelia in April of 2021 was hired by Lourdes West Pascal Family Medicine as a behavioral health specialist. Her job includes providing preventive counseling services and coordinated care between the patient's psychiatric consultant and primary care providers. This is all part of a collaborative care program designed to provide integrative care for both medical and mental health needs in one primary setting, with the goal to promote better outcomes and improve continuity of care. Her educational background includes a BS in psychology and a MS in clinical mental counseling. She has worked 10 plus years in the mental health field and other helping professions. She is licensed in the state of Washington as a LMHCA and nationally certified by the NBCC. So those are their bios. And I will have Becky go first, and I will stop sharing my screen so you guys can go ahead and start your presentations. And I will have your presentation pulled up here in just a little bit, Becky.
Great, thank you, Martine. You set me up very well with your presentation for mine, so that'll be great.
Thank you. Okay, take it away, Becky.
Oh, that one's
Sorry,
not mine.
wrong one. Sorry about that. There we go.
All right, great, thank you. As Martine said, my name is Becky Starnes, and I'm the Program Director for Connect, which is part of Community Health of Central Washington, and we do medication-assisted treatment. Next slide, please. So we're going to talk today a little bit about buprenorphine, what our program entails, and then some of our partnerships. So for those of you who are new to this topic, I just wanted to give a little bit of an overview about what we do. So we prescribe Suboxone, Subutex, also known as buprenorphine, for opioid use disorder. We do that in an integrated care model. This medication only works for opioids. So it helps patients with their cravings, withdrawal symptoms, and it does help for pain. So for our folks who maybe were on a chronic opioid due to chronic pain concerns, this will also help with that. It can precipitate withdrawal if it's taken too soon. So we need patients to be in at least moderate withdrawal prior to their induction, which is when they take that medication for the first time. Next slide, please. Next slide. Oh, thank you. So what is OBOT? Today we're going to talk about office-based treatment that's incorporated into primary care. So that's our model of care. We are integrated into the primary care setting. We basically go into any of the pods that are available that day, and we set up our clinic within the primary care clinic. This is being more widely used now in primary care than it was when we started this program almost 6 years ago. And some of the barriers that Martine talked about earlier also have impacted this ability to be able to do this type of care. Insufficient nursing support. It's a pretty high intense, high touch model. So we have a high nursing need for this population. Insufficient office support. Office staff stigma can be an issue, and that can be a barrier to care, people coming into the clinic. So we really want to make sure that we're addressing that. Payment issues, as Martine spoke of earlier, a lack of institutional support, and then just really complicated systems for our patients to navigate. Primary care, FQHC care is not the easiest to get into, especially for folks who may need help getting their insurance established, or they've been treated poorly by either a previous physician or at the emergency department. So those are all things that we try to navigate in our program. Next slide, please. So what makes our model of care a little bit different? For the Connect team, we have a dedicated team, and that's all we do. We only do Suboxone treatment. So right now I have a department of 12. When we started this 6 years ago, it was just myself and a nurse care coordinator and a provider, and that was it. And now we're up to a team of 12, which is amazing to me. I have 3 RNs. We serve a 2-county region, so Ellensburg, Kittitas County, and Yakima County. So I have 1 nurse for each county, as well as a lead RN that supervises my nursing and MA staff, and then also fills in as a backup when my nurses are out. I have 3 medical assistants, again, 1 in each county, and a float that fills in or also helps when we have a very busy clinic. We have our own behavioral health consultant, and he travels back and forth between both counties, as well as working out in our Natchez clinic on a chronic pain pilot that we're currently working on. So he sees patients in that setting as well. We have a program assistant that we hired to help reduce some of the barriers that I'll discuss in a little bit. We have a community liaison position that's specific to Kittitas County. This was a grant-funded position that was part of the KCHN network. I saw Robin Reed on earlier. I don't know if she's still on, but this is a position that helps with some of those collaborations in the community. So that position really works with all of the MAT providers in the area, works with the jail, helps do training and community support. Then, of course, we have our prescribers. We have 1 medical doc at this point. I'm trying to think. we've had several different ones, and we have a couple of physician assistants who are really fantastic. Yep, next slide, please. So decreasing barriers. I talked about hiring our assistant, and really one of the things that we learned pretty early on is that when people are in active addiction, it's very difficult for them to make and keep appointments. It's difficult for them to navigate those systems. So we do all of our own patient registration. So when a patient comes into clinic, calls, they get directed right to us, where we kind of decrease all of the barriers as far as registering patients, helping them switch insurances if they need to. We do all of our own reminder calls. Anybody who's worked with these patients, sometimes they will find excuses to not come to their appointments. So we don't want to give them that automatic reminder that says, would you like to reschedule? Because a lot of times they'll say yes. And so this way we are making a lot of contacts with them. We're talking to them directly. If they are running into a barrier with transportation or something else to get to their appointment, we can help navigate that for them to make sure that they make it to those appointments. We do all of our own scheduling. So my nurses actually schedule all of the appointments for their patients, so they're not having to call the clinic and try to schedule through reception. One of the things that we do that's been super successful is that we schedule that next appointment before they leave the appointment that they're at. So when they leave their visit, they already have their appointment for their next visit. We print that out, we hand it to them, and so they have that when they leave. We also give our patients the direct line to our nurses, so they can call right to the nurse's desk, talk to the nurse if they have any questions about the medication, about scheduling, if they need to move an appointment because they are working or they have a childcare issue, they call the nurse directly. We see our patients even if they arrive late, and that's very different than primary care, where typically if you're 15 minutes late or 10 minutes late, they may need to reschedule you because, again, like Martine said earlier, primary care providers are super, super busy. What we do is we're going to work them in. If they show up for that appointment, we want to see them. We know it's really critically important to see them, to make sure they have their medication so that we're reducing that overdose risk and that risk of death. If patients haven't arrived 15 minutes after their scheduled appointment, my nurses or my medical assistants get on the phone and they start calling them, and we'll continue to call them multiple times throughout clinic. And if they pick up and they say, oh, well, I couldn't get a ride, or, I wouldn't be able to be there for another hour, we say, do it, do your best, we're going to wait for you. And we will wait and see that patient. As long as they make it in before the close of business that day, we're going to see them. We do use clinic reception to check in our patients. So the patient would walk into the clinic just like any other patient receiving any type of service. They would be checked in at the front desk, just like any other patient. And then at the end of their visit, our Connect team checks them out. So they don't have to stop by reception. We've already given them their next appointment, so they don't have to do any type of checkout. Next slide, please. So how do people get referred to Connect? One of the things that's interesting about being integrated into a primary care setting is we are not seen as specialists. So we are just another arm of the primary care team. So patients have to be primary care patients of our clinic. So if they're not already a CHCW patient, that's where our program assistant will come in and help register them as a new patient and help them get all set up in the system. We can take referrals from primary care providers within our system. We take provider referrals from OB/GYNs who have pregnant patients. We get referrals from our community partners. I know Michael Clement is going to speak next. He's a partner of ours up in Ellensburg, and we do a lot of collaborative care with Merit up there. So once we get that referral, what we do is we put it what we call a waiting list, which isn't really a waiting list. It's just kind of a log so that we can keep track and make sure that we have all the information that we need on the patient. Basically, we add the patient to that list, and then right away, the nurses and the program assistant start working on when can we get that patient in? How soon can we do the intake? Who will do the intake? Typically, I do most of our new patient intakes, but I also have my lead RN do intakes with patients. And then how quickly can we get them seen? So, and once that happens, then the program assistant will contact the patient, make sure their insurance is verified, everything is ready to go, get them scheduled, and then we will see them for intake. Right after that, we do the meet and greet with our provider, and that's where the provider assesses the patient, make sure that the medication is appropriate. I've already done most of the history, drug use history, a little bit of medical history, any trauma that the patient has suffered. We talk about previous legal incarcerations or charges that they may have. So the provider has a very comprehensive picture of that patient prior to walking into the room for the first time. We also do what's called a home induction, which just means that when we see the patient, we write them a prescription. We give them very good tools on how and when it's safe to take that medication. The RNs do a great job of teaching them, and then they take that medication home. They start to go through withdrawal where they're comfortable, and then they take that first dose on their own. Next slide, please. So 42 CFR, we've touched on this a little bit. It is a higher level of confidentiality compared to HIPAA. There's no real continuity of care. We can't share information even with the primary care team within our own organization. The patient has to sign releases of information for us to share any information, and that information really needs to be limited in the scope. Unfortunately, this has been a barrier for some of our patients in the past. We've had women who have been fleeing domestic violence situations, have left the community, called us from Spokane and said, hey, I really need a prescription. And unfortunately, we don't have that release to even be able to send a prescription. The reason this pertains to us, even within the primary care setting, is because we have that dedicated team. So we are seen as an SUD provider, even though we're in the primary care setting. So how does this work in an integrated care setting? Next slide, please. One of the things that we developed was an internal release of information. And I know this is really difficult for you guys to see, so I'm going to just kind of go over the highlights a little bit. We put the patient's name on here. We talked to the patient about, is it okay for us to talk to your primary care provider and their team? And by their team, we're including their practice partners. So if they're being seen by a different provider that day on their primary team, that's covered, as well as their BHC, the reception team, and their nursing staff. We also have pharmacy listed on here. Obviously, we want to be able to talk to our pharmacists, and if there's any issues, we want to make sure that we can get that medication taken care of for the patient. We also have a care coordination department, and a lot of our patients need some type of care coordination. So we talk to them about that. What does care coordination mean? What does that look like? What kind of information would we be sharing with them? And then up in Ellensburg, we also have a dental team. So that would include our dental providers, dental assistants, hygienists, and their reception staff. We also make sure that we have the 42 CFR language on this internal ROI, just to make sure that we have everything covered. And we really discuss with the patient why it's so important to share information with their primary care provider. As Martine said earlier, it is the patient's choice. And so if they don't feel comfortable for whatever reason, we're going to respect those wishes. We do revisit this with patients often so that hopefully we can get them to see why it's important and build that trust with their primary care provider and with us. Next slide, please. So connecting patients to primary care. We do not do any primary care typically in our Connect clinic. And what I mean by typically is that if we have a patient that comes in with an acute need, they have an abscess, they have something urgent that needs to be taken care of, we are not going to hold up patient care for that. But we're not going to take care of any of those chronic conditions. And one of the reasons for that is we really want to hand those things off to the primary care provider and build that bridge between the patient and the primary care provider. One of the things that we do to help with that is that we assist patients in clinic to fill out that clinic paperwork. Again, that can be another barrier for patients. We give them this big packet of paperwork when they're a new patient to the clinic and they need to fill that out. It can be very daunting or intimidating for patients, especially if they're in active addiction. So in Ellensburg, my community liaison works on this paperwork with new patients, and in Yakima, my RN lead works on some of this with my patients. Then we complete those releases of information. Then we do a warm handoff to reception. We walk the patient to the front desk, ask reception to schedule them with their primary care doctor who's already been assigned to them. And then we really encourage the patients to keep those appointments and engage with primary care. Next slide, please. So what are some of the critical areas for the PCP and their team to be involved? Really, our pregnant patients are very important. We want to make sure we have really good quality care, whether they're getting their OB care from us or not. If they're getting primary care from us, we really want to keep that primary care doctor involved all the way through. Surgeries or procedures are really important as well. And one of the things that we found really early on is that there were some struggles with our patients with medications after surgery. Typically they're given, enough medications maybe to get them through 5 to 10 days. Our patients would take those in 3 to 4 days. Then they would be calling their primary because the surgeon is not going to prescribe anything else and wanting their primary to prescribe something else for that pain. So we work really closely with the primary care doctors and help them navigate getting that patient either back on Suboxone, increasing their Suboxone dose, but helping the primary to manage those post-op pains. Behavioral health as well. We know that there's a lot of triggers that go along with substance use disorder. But there's also a lot of untreated health conditions that have happened over the course of many years where our patients may or may not have accessed primary care. And so we also want to engage in behavioral health to help with those conditions, whether it's diabetes or asthma or, sleep, where people have that chronic pain piece and they don't sleep well, and then they don't sleep well, so their pain increases, and really give them some additional tools to manage all of their primary care needs as well. Again, coordination for their pain management, and then any other type of medication management. We know it can be a struggle for people who need to be on some type of medication. So we really want to coordinate with the primary care team to make sure that we're able to keep patients on all of their different medications. Next slide, please. So we know that it's really important to include primary care, and our program is really a nice gateway to get patients into clinic. Again, these patients may or may not have been seen for any type of medical issue in years. And so getting them engaged with us, building some trust that they can trust the providers that we work with, that they're going to be really well taken care of is important. Really getting that holistic care of the patient. We want to improve those health outcomes, and we know that by having more people involved and really looking at the person, the whole person, we're going to have better outcomes for them. It's also nice to just have those additional supports and have other people kind of keeping their eyes on that patient. And if people notice a change in behavior, that they can let us know, hey, we had this patient in this week, they weren't really acting themselves, you might want to check in on them. So again, just kind of making sure that we're really looking at the person holistically. Again, helping those patients navigate systems. We have some really cumbersome systems that we put in place that can be a barrier. We also want to make sure that we're working with primary care providers who may have some anxiety about working with these patients. They aren't sure how to treat somebody that has an OUD. They may not know much about Suboxone or how it works. And so this is our opportunity then to work with those primary care providers and train them, give them information, help them support that patient, and really try to decrease that stigma and that bias that comes with this medical condition. Next slide, please. So stigma, bias, and discrimination are some of the things that we hear most from our patients. One of the biggest barriers to seeking primary care or going to an emergency department. Even our patients who are in long-term recovery, when people find out they're on Suboxone, they just kind of get that, oh, yeah. So we really want to help educate people about that. We want to look at labeling, negative stereotypes, othering those patients. We know that that comes across as unequal health outcomes for these patients. They have poor access to economic and political power. They face a lot of blame, a lot of pessimism. Oh, they're not really going to recover from this. They're never going to, come out of this. They're going to continue to use. We really want to let people know recovery is possible. And if we all work together, it makes it more possible. We all have dealt with social distance over the last couple of years, and our patients feel this all the time. They may have lost their families, their friends, their job, and they're very socially isolated. And so really looking at how to increase the socialization for them is important. They can also be seen as dangerous, volatile, threatening. And so we really want to look again and show people that that's not the case. For the most part, 99% of the time, we don't have that issue. So what can we do? Educate, just like we're doing today, talking about these issues, educating, giving personal witness, putting a face to recovery, really talking about that recovery is possible. And again, showing our primary care doctors that when we engage with these patients and we treat this medical condition, they can recover, and this is what that looks like. And having those PCPs see that type of success will increase the referrals back to us as well. When they know their patients are being really well taken care of and that we're making a difference, they're more likely to continue to refer and to reach out and to ask questions and to want to educate themselves. It's really important that we use person-first language. And so for clinicians, if there's any clinicians on the line, your words really matter. How we talk to and about patients matters. So we really want to watch terms that may induce implicit or explicit bias. So, you know, we talk about eating disorders. We don't talk about food abusers. We want to talk about having a substance use disorder compared to an addict or a junkie. You know, abuser implies a willful misconduct, and a disorder is really more of a medical malfunction. And we want this to be treated like any other medical condition because it is a medical condition. Dirty versus clean. We hear that a lot with our urine drug screens. Do we use that type of language for any other type of medical test? We talk about our drug screens as being consistent. Things that are in there are supposed to be in there, or inconsistent. There's something in there that shouldn't be, or there's something missing that should be. Next slide, please. That is my contact information. I'm happy to answer any questions if anybody wants to reach out about what we do or how we do it. And I'm happy to share any information. And I think the last slide is just if anybody has questions.
Thank you, Becky. And if anybody has questions, we'll have a few minutes here at the end of the presentation. And I will get the slide for, or actually, Michael, you're up next, and you did not provide any of the PowerPoint, so I'll let you go ahead and take it away.
Can you hear me okay?
Yep.
Hi, everybody. My name is Michael Clement, and I am the clinical supervisor here at Merritt up in Ellensburg. I came on board here about a little over a year ago, and I became partners with the practice transformation program here. And it's really been awesome to see a community really come together. The guy in that film said something about, what did he say? He said something about an any door model of care. And I found that to be true up here. You know, we have people that go into, whether it's going to the Connect Clinic or any of the other providers that we partner with here, it starts the ball rolling, and our patients get to they feel more cared for. You know, they have warm handoffs to treatment, warm handoffs to the hospital, more warm handoffs to social services. And so that's been really neat for me to see. I'm supposed to talk to you about a little bit about interagency communication and community building. And one of the questions is that how do we educate our patients about the benefits of connecting with a primary care physician? Well, we use ASAM criteria, and in Dimension 2 is the biomedical conditions. And we talk with them about that during admission, individual counseling sessions, and also during the assessment process. And we make referrals according to if there's any barriers to treatment or any social services they may need to help with their health. We communicate mainly, we have meetings set up. I saw Robin and Pam and Becky in there, and we meet often. At least once a month, we meet with the Connect MAT team. And then every Tuesday morning, we have a platform where we have a Zoom meeting if we have people that we need to staff with medication assisted treatment and other medications that people are taking. We also do random drug screening here, and Oftentimes we communicate back and forth with if we're seeing discrepancies in those, and try to help engage the person more in services, and try to keep them from going on full-blown relapse or something if they're using again. One of the things also that we do is we meet for lunches. We participate in other opportunities within the community. We work with, we have a Recovery Navigator program that's rolling out, and they work closely with first responders, and they make referrals according to what the problems are. If the officer was called out due to a mental health issue, a lot of times those recovery navigators can help get them to their first appointment, help make referral, and the same thing with SUD situations. So we work with Central Washington University Crisis Care Management Services. We do assessments on campus if we need to. We work with the police department, the sheriff. We have a mental health provider, and we also have an SUD person that's staffed in the jail. We're working with the case managers from the hospital, from the emergency room, and we get referrals that way also. I think somebody was talking about it earlier about people that come in the hospital, whether they're alcohol poisoning or drug overdose, things like that. And those case managers refer according to what they find there. We meet with probation, behavioral health court, drug court. We meet with Department of Corrections monthly to staff patients. So we're really working in almost every area of a person's life. We know it's a biopsychosocial disease, and all those areas get addressed by the referral process from any door that someone will come into. That makes sense. We can expedite referrals to primary care for Central Community Health of Central Washington. That means that we can call a contact person at the office and get a primary care appointment immediately. Some of the ways that we provide confidentiality and releases and things like that, or case files, we use box.com. We don't have secure email yet, but we are coming to get that. So we're HIPAA 42 CFR compliant, and we use Box, and we give the Community Health of Central Washington access. We have probation that has access to some of their people, and we're able to upload and download referrals, releases of information, assessment summaries, monthly status reports, discharge summaries, shared care plans, etc. We also utilize the collective medical alerts we get from KBH, which is the Kittitas Valley Hospital, and we're able to track patients that are overutilizing the ER department. Many times we'll get the alert, the collective medical alert, and a person, it may be their fifth or sixth time in the last year that they've been in the ER, and we get to see what they've been admitted to the hospital for, or what they've been seen for. And a lot of times with collaborating, those people tend to not become repeat patients in the ER, which cuts cost a lot. We have MOU signed with Community Health Central Washington, and that's for coordination, collaboration, and partnership in our practice transformation program. We yeah, we meet with we even have, we've met with the library, which is right next door to where our office is. There's a lot of homeless people and behavioral health issues that go on, you know, right next door to us. And the library had asked for us to meet with them, collaborate with them, and so that they have a way to point people in a direction also. So some of the benefits of being in communication with the PCP provider, we here at Merit, we provide with a SUD or co-occurring diagnosis, treatment recommendations, monthly reports. We ask patients if they have a primary care physician, how long it's been since they've seen a primary care physician, and we connect them with our community health of Central Washington. If there's any other chronic illnesses like diabetes, heart disease, Hep C, we encourage patients to meet regularly with their PCP and coach them about only using the ER in serious medical emergencies. I know that we've implemented, we've started using the PH9, the GAD7, and the PCL5 screening tools that upon entering treatment, we have those screens, and we're able to track over the 30, 60, and 90 days. We can track progress. A lot of times, if somebody's not taking any kind of medication, and sometimes the substance use disorder can mimic mental health issues. And so we have often seen people come in and their anxiety diminishes over time, and with treatment and getting into community support, and we see anxiety go down. And you know, the medication assisted treatment program that is put in place here, we work alongside with the Connect program. We have people in treatment that are with them, and you know, we also try to reduce the stigma around behavioral health, SUD, mental health issues, you know, by allowing people to, you know, be treated both with medication and treatment. It's a great combination, especially with the opioid use disorders. And we've seen a lot of success so far with that. So I don't want to go over my 10 minutes too much, but if anybody has any questions, just let me know. You can always contact Merit and ask for me, and I'll be able to answer any questions outside of this forum. And if you need help with collaborating with community, with other people in your community, we can give you ideas on what we've done in the past. And I think it's really been an awesome experience to be part of this. And we've really seen the community as a whole come together in helping people here. And it's really nice to see this. So that's all I got. Thank you.
Thank you, Michael. And we'll have you go next, Armelia, and we won't have time to do the breakout rooms just because of time. And if Chelsea, if you can put the link to the survey about the Learning Collaborative on the chat, please. And if you guys can go ahead and fill that survey out, that would be really helpful for us. And let me share Armelia's PowerPoint and go ahead and take it away, Armelia.
Hello, everyone. I'm Armelia Bazzini. I work for Lords West Pasco Family Practice. I am the behavioral health specialist for the collaborative care program here. And we've been talking about that a lot today. And Martine talked a lot on some of the similar points. We use our programs based off of the AIMS, which is developed by University of Washington. And basically, it provides the patient in one setting a holistic type of care. Next slide, please. Okay. So here over at Lord's, I have my own office that's there all the time. And I'm coordinating care between primary health provider, a psychiatric consultant, but we also have more than the original AIMS program because we have our nurse navigator, Sarah Cashman, I think I saw her on there. And we also have soon to be a community health worker, which will be really great. But the behavioral health specialist position is basically coordinating all that care while providing also brief interventions for mental health needs. And Martine talked a lot about the benefits of the collaborative care program. Obviously it's evidence-based. It provides preventative care, which is one of the greatest things. It's trying to catch people early and reduce the amount of time it takes for them to get to recovery. And one of the big things that help with that is what is known as the warm handoff. It allows us to have higher capture rate, which is another one of the benefits, because a lot of people will not say schedule their appointment, or they will say, I'll think about it. But if you have a behavioral health specialist in-house that can just stop in, meet with the patient, give them a brief education on it, or even just meeting with them so that it's not so intimidating, because there is a lot of stigma surrounding counseling services, what to expect, and all that runs crazy in their head, and eventually they're canceling before the first appointment. So it helps a lot to meet them first and then to schedule an appointment before they leave, which was one of the recommendations our team made. As well as we also have a handout, which is helpful and was one of the suggestions made in a book Dr. Taylor gave us on integrative care. And we developed that to give to a client or a patient if for some reason the behavioral health specialist was not available. For instance, if I'm in a session, they can hand that to them. They can see the pictures of the providers, including our psychiatric consultants, and know who they're going to see and why it's beneficial, why it's different. Not to mention better continuity care, better medical outcomes, and there is a faster recovery rate for patients in collaborative care versus regular care. Next slide, please. One of the questions was how we educate the patients. I did briefly tell you a little bit about that, but when they're identified by their primary care provider or the MA using the PHQ-9, their provider will talk to them a little bit about the program, ask them if they would like to meet with the counselor for one handoff or if they would like information. And that's the first education. The next one is with the warm handoff. And then again, when they come in, there is an informed consent process where I go over the program and all the expectations and all of that kind of thing. Next slide, please. So the big part of today's session was about how we're communicating. And I think that's probably the best part about this program, the thing I love the most. I'm no longer a counselor on one side saying, go see your doctor, and never knowing what's happening on the other side. I am able to walk down the hall, communicate with providers, and we use Athena Health quite a bit. And it helps a lot with understanding what's going on with the client. We chart in the same chart, so we're able to see each other's notes. We're able to use secure texting and sending patient cases back and forth of things we need. It's also really nice to be able to check and see, okay, they're on these medications, because a lot of times patients don't remember what they're taking or how much, and giving them appropriate medication education means knowing what medication they're actually on. It also tracks all of our PHQ-9s and our GAD-7s and other assessments that I utilize for the program. And it shows it on a nice little bar graph so I can see if they're making progress. not making progress, in which case it allows us to reassess and readjust treatment if they're not making progress. We also use workflows that are shared between staff and of course just provider to provider. And I utilize this one more than anything. Any spare moment I have, I walk down the hall and I just check in with each provider, and that alone, they're like, hey, let me talk to you about this. Let me talk to you about that. And you're touching base each day, also learning what each provider prefers for communication. It's not as a team sport and the behavioral health specialist coordinating, it's important to know what their preferences are, what makes it easier for them to provide the care, because they are more limited than I am on time. And so if they prefer to use the case, or if they prefer to use, just face-to-face, come up, ask them, or stop by and drop off something so that I know to contact these patients, and then I document. We also use the AIMS tracker, which helps us also track the progress, track the PHQ-9s, and be able to know if we're providing adequate care, if it's going in the right direction, and if we need to readjust or make some changes in the care. Next slide. So this is an example of one of our workflows, and this one is just about the initial contact with the patient. It goes right from their meeting the customer service representatives up front to the MA, to the doctor, and then whether or not they're going to meet with behavioral health specialist, or if they're going to get a referral. And that, next slide, please. And this is the one I was talking about earlier about the collaborative care versus the usual care. And I really wanted to put this on here because it gives some good information on the difference. If you look down there in the usual care, about 20% of patients show significant improvement after 1 year, as opposed to, I believe it was 50% on here in the collaborative care. Not to mention that they show improvements a lot faster. And you can see in the green, that's the collaborative care outcomes versus the usual care outcomes. Next slide, please. And so here are some references, but if you just go to Google and say UW AIMS program, they have resources on everything to do with collaborative care, from down to how to introduce your care team, assessments. They have, they have workflows. They have a bunch of resources and they're free and they're worth checking out. Does anybody have any questions?
Thank you so much, Armelia.
Sorry, I talk fast.
No, it's okay. It's okay. And we're right at 3. So our next learning collaborative will be on April 28th from 1 to 3. And the topic is going to be the role of peer supports in providing care. If you guys have any questions, please feel free to contact either Sam, myself, or Diane, and we can connect you with any of the presenters that presented today. And the slides will be available on the GCACH website later on this week or next week. Thank you so much, everybody.
Thank you.